you chose was that email questions usually are preferred to minutes. But very nice.
He has a history of substance use, but she just had a DKA yesterday. Medication. It was like they told me to call you. And I'm like, well, that's my attending, but you know,
Usually,
well, if he wants to start off the doctor,
depending on how passive aggressive I want to be, one of the things I usually will put in the note is that is there a history of opioid use disorder?
I believe so,
Yeah.
yeah.
I usually say, given the past history of opioid use disorder, patient is likely to require higher levels of analgesic, otherwise they will not. Yeah. All right. Everything, everywhere, all at once, right? Everybody's good with that. All right. So where do we want to start? There's no real answer here.
I thought it was very interesting, the dynamics between the three generations of a immigrant family, and the understanding level of like modern times and modern understanding of relationships.
Mhm.
So this specifically is seen when there is the obvious different influencing in Chinese. And so the daughter is trying to introduce her partner to the grandfather and doesn't remember the word, and the mother uses this as a chance to tell her own story of how she wants the grandfather to view this relationship.
From a psychiatric perspective, relevance. I mean, I need you to consider that any one of these characters would present to you. Now, if they present with actually complaint of blank, and in your medical opinion, there is no clinically significant distress or impairment, there's probably not much to get, right? So we don't pathologize behavior, but I think for a thought exercise, especially a teaching didactic, we assume that the reason why the patient's coming here, making it important to see you, is because they are or experiencing some level of clinical stress. Given that, and then focusing on your observation, how do the two merge?
I think in this could be a stretch, but I think the mother's response could be a somewhat programmed response to trauma, because she has a past history of having a bad relationship with her father, both with the repeating scene of her like running and him yelling at her. And so it could be a trauma response to almost protect her daughter, but she's not understanding that it's also hurting her daughter.
Well, let me ask too, because again, there's no wrong answer here either. Who's presenting to you? Who is your focus?
I guess in this case, the wife would be, or maybe the grandfather is presenting with declining function, and you see the family all in the room together because you need the family there as translators.
I feel like all three present easily, like very similar.
Who do you like to present first?
Well, talk about the grandson, but I feel like I can see that being like a difficulty with the state of life as well, right? Because you're with like despair and seeing how the family that you be if it's continuing or prospering the way that you thought they were. The intergenerational things that looks like they're getting.
And when either the grandfather or who was ever calling on behalf of the grandfather contacts your office, and your front office support asks, what's the reason for what's the reason we want to see the doctor? What are they going to say?
That they want, I guess in this case, it would probably be the daughter reaching out to the office to schedule something for her grandfather, or not for her grandfather, for her father. And I think she would probably be asking about like, is like just looking forward to see how like they decline in life, and like ability to carry your daily actions will affect your mood and things like that. It being that I'm a psychiatrist in this setting.
And then having watched this film, filling in between the lines, what are some clinical observations you have given that speaking time? And this is you collectively, I'm not just picking on the one brave enough to speak first.
It depends on the jury trauma, and you consider like you would probably rape and trauma during the course of the child. Depends on like serious changes with upheaval, and then immigration, how that impacts the church there, how much feeling someone who can be speaking in a home where the people speak Mandarin, and then in a country where people speak English, so that's part of the very backward as well.
So what do you want to do, then? How are you gonna address what's going on? Again, you collectively. Unfortunately, I'm facing you, so it looks like I'm actually addressing you. Good thing I have wheels.
I would speak with him and his what seems to be a support system and talk to him about seeing if they're like if he could engage in some activities with people who are similar to him, who understand his culture, or people of similar ages who had similar upbringings to see so that his life wasn't so stagnant as it seems in the beginning.
My gut says that the daughter's response to you is that she's probably tried that. And she wouldn't have called you if it was successful. So
I would probably because there's many that tell me the name is going on. I want the family there, but also like talk to him one-on-one with his translators. Because I feel like he would be different than everyone else is there.
Mhm.
And I would be encouraged to kind of share about like what's been going on. I think like if he is something called, I would want to do like individual therapy, talk about like the path for that history.
what's likely to appear on your treatment plan as an individual therapist? I mean, right, the treatment plan means that you have stated objectives. And then what you're doing to reach those objectives. So, and objectives are probably going to align with most likely diagnoses, secondary, tertiary diagnoses. If anyone here got a peek at our resident psychologists treatment plan, what might you say?
Maybe work with him to define a goal or something.
She did.
That's sure. But maybe goal was a bad use, but a current purpose to so that he's not just. It seems as if he's as you said, disappointed with like the prosperity of his family and his life. So he's not just ruminating on that all the time. Maybe he could distract himself with a hobby of some sort or
Look, still getting to the planning stage yet. I'm actually interested in the actual bullets that appear on her treatment plan. Again, by definition, at least in this room, it may not, and this may not be apparent, and it may not even be in the movie. He's suffering from clinically significant distress and impairment due to these. What are you likely to see in this treatment plan?
I feel like you were very close to what you were saying. I would just think about a little bit of what we want you to do probably because of what you want.
I heard isolating or ruminating.
I don't know if this word that would distract him, but like give him something else to think about.
Increases like self-care and coping skills, like starting to engage in behavioral application.
What evidence do we have about his self-care? Let's go a couple of facts.
What don't we have often in like actual code, no, in the video. They want to increase the ADL.
Generally speaking, then, in someone who comes in with declining ADLs, what is something that is in your differential APA, perhaps on our treatment, for treatment? Yeah, I would hope that at some point during this movie, I would hope that at some point during your clinical evaluation, as a clinician, you're considering dementia. Right? Like, Now, on the other hand, I'm hearing other things too, rumination, I'm hearing isolation, dissatisfaction. I heard words from Ericksonian theory with regard to ego integrity and despair. Taking all of these and bringing them together, what is a differential diagnosis of dementia that a clinician would first investigate before perhaps rendering a diagnosis of major neuropathic disorder?
Should
Yeah, I mean, if the patient's depressed, individuals his age tend to present with signs and symptoms suggestive of dementia, hence the clinical term pseudo dementia. All right, so that's one of the things. And I heard you already told me a bunch of things you're going to do: individual therapy, certainly support groups, but they're all towards the goal of alleviating dysphoria and perhaps major depressive disorder, right? And in this case, I think actually calling that a DSM, hoping that you see, not that I hope to see, but certainly expecting to see CGCAPs is probably going to be a little, how do that? I don't think it's going to happen here. But then again, generally speaking, the elderly population, you don't expect to either. When you're a geriatric depression scale, and again, it encompasses that term, pseudo dementia, right? Cognitive deficits are the presenting sign of major depressive disorder in this aging population. And that's even when you don't take into account this cultural aspect, right, of what's going on. Right? All right, so depression in the elderly. Let's say he in fact rules it. Let's say whether it's through geriatric depression screening, your single best diagnosis is major depressive disorder. What else do you want to know? What else? What other information that is part of your routine psychiatric assessment do you think is noteworthy?
history of depression. Yeah.
Yeah, I mean, I definitely would want to know any prior episodes. I certainly want to know if there's any episode of mania, because all it takes is one to just switch gears, end up in a different chapter in the DSM, the bipolar and related disorder chapter in the DSM-5. Anything else?
Other medical conditions.
Yeah, I mean, he's elderly. I mean, if you're going to tell me this is his first episode of depression in someone who is 70 plus, I'm a little concerned that it's a little bit of an atypical onset. And we really have to investigate the underlying medical conditions. Is there any, other than age itself, any other evidence in this film that he has another underlying medical condition? Yeah, yeah. So that's certainly something we want to investigate. Anything else? Polypharmacy for an elderly patient, maybe not agree. Yeah. Yeah. So due to the direct and physiological effects of the substance, and be careful of practicing ages. Just because quote unquote he's older doesn't mean he won't be abusing drugs, right? I mean, a woman to the tilt. That's high clinical index of suspicion. Anything else here?
I guess it's not your job to investigate what elderly.
So I gave you this morning discussion. Well,
Yeah, report you they can investigate.
Yeah.
anything else? With regard to this clarity.
So one of the questions I have watching the film is like, do you experiencing these are like experience whole world and stuff, like I think the interview could get a brief picture, but if you like he's seeing something, I wonder if it's part of the or maybe that's future.
Yeah. You know, and is there another question we got now? Well, that shouldn't be over. All right, so we're going to do it alone and then with the family, and then you get this other information about his daughter experiencing these astral plants. I mean, that begs the question, isn't it?
Has he ever experienced something similar to that?
Well, I did. He didn't. Yes, you're right. And let's say the answer is. And again, the reliability of that answer, we're not really certain. This is an initial psychoval, but let's just say the answer is no.
I think what that's looking means that after the time they're experiencing astral plane could be culturally appropriate. I want like more information to make sure that's the order.
Let's say it's again for academic sake. Let's say it is causing clinical distress and impairment now in his daughter. Well, yeah, but I think there's still something that's fairly straightforward here that we're missing.
Are you trying to get at whether the elderly gentleman's hasn't been told that maybe that's what he's fabricating, like out of a delusional, kind of like along the lines of a delusion, or is that something maybe his daughter actually is mentioning, maybe she has her own problem? Is that where you're trying to go?
I think your daughter can own this,
Oh, okay.
right? And once she does, I think there's a major question that needs to be asked, right? Yeah, because we just said that we're gonna rule out the direct and physiologic effect of the substance with regard to his depression, pseudo dementia. Now we have evidence that his daughter may be using it. And even though he may not be experiencing any actual pain, or, out of body or out of fully experiences, that drug may be inducing a depression. Right, so even if he's without that psychotic process or the dissociative process that the daughter might actually be communicating, the role of substances thought to be investigated, and that we have, I think, even a higher index of suspicion that substances are in the house. No, all right, yeah, you guys will go there, right? I mean, you told me that you would for him, and now with this added evidence that she's experiencing what she's experiencing, I think that would even be stronger. Stronger.
So you're implying that the same drug in the house is causing different, like it's manifesting differently?
Absolutely. Yeah, so even when you might even ask him about dissociative type of episodes, and again, I think since we just discussed this last week, it's probably good to review it now. But he says, no, I'm not so sure I can leave that discussion just yet, because what's on the table is your depression. And there might be a role of substance here. So even though you're telling me, he might even look at my daughter. Wow. All well and good, and it's like good that you're not experiencing those as well. But I still want to know the potential drug's role, what you're experiencing, which sounds like depression. So, what are the questions you're going to ask? And again, we'll pull that from just last week's conversation, just because we just discussed it, and it should be fresh in your mind when it comes to reviewing dissociative states. When you see that question?
Yeah.
So number one, generally speaking, and again, the wording, obviously, I'm talking with third year medical students now, but the wording may not be used exactly the same way with patient or the patient's family. But number one, are there any aspects where you don't feel that you're yourself in some way, you're separated from yourself, or you're separated from your environment, right? So aspects of depersonalization and or derailment, right? So now again, you can give examples, the out of body experience, for depersonalization, the subjective sense of deja vu, or derealization, right? So that would be number one. And then this could be a straightforward question during the actual evaluation, or perhaps testing for this during the mental status examination, but memory and therefore gaps in memory. So any amnesia. And then I want to know real dissociative state, especially if there is evidence of it. Do you end up in a different part of the house, outside of your house? Now remembering and now recalling, do people tell you that after you find yourself where you are, that you seem strange in some way, maybe a different voice, those types of questions. Then of course you're going to get much more information from the family than having the family communicate with your patient with now telling. But I think the first question goes to the person, and then you could bring in the collaborator.
Question for dissociative amnesia, do you require like the patient to forget like autobiographical information in order to arrive at that diagnosis, or like what, or do you just need like the depersonalization and realization alongside the amnesia to arrive there?
All I need is gap in memory.
To get dissociative amnesia. So how would that be different than like
Amnesia.
Yeah.
Because with amnesia, it's not due to the direct and physiologic effect of the substance or a medical condition. Therefore, in your medical estimation, your medical opinion, psychological variables would seem to be central, then it becomes associated. And your exam, achieving the differential to really kind of exemplify that differential is a transient global. So review transient global amnesia, because that could show up as a single bit during the section. But when the amnesia is not due to the effects of a substance or a medical condition, choice C is other, meaning due to mental illness, and dissociative amnesia should be at the top of your list.
Through the formal scale, you can use for such a associated experience with scale too. Like the likely to ask questions based on the score, feel like whether it would match up more with CID.
I mean, if you look at the DSM criteria, there's really two that are stated. Number one is that there are gaps in memory that are not attributable to quote unquote normal forgetfulness. And in addition to that, those gaps in memory are not induced by the effects of a substance or a medical condition. That's really it with DSM.
So once you take those out, then dissociative is the only thing I would think.
Not the only, I'm sure there are others to consider in terms of mental illness, I mean, manic episodes.
Yeah.
Psychotic breaks, but mental illness in general, and in that differential, the system means you should be at the top. Okay. So again, let's say for just discussion's sake, your patient, our elderly patient says, no, none of that. And then collateral information supports, nope, none of that. Then you have to investigate the role of substances with regard to what he is presenting with, which seems like, at least in our differential, a provisional diagnosis. Right. Questions? We kind of alluded to this this morning. Didn't quite go there in the tangent when discussing Seinfeld, but probably good to go there now. Since we're talking about this particular topic, chapter in the DSM of the depressive disorders, other than major depressive disorder, what are the other conditions published in this chapter? Dysthymic disorder or persistent depressive disorder, right? So I think any of those combinations would appear on a chapter, maybe in parentheses to really help you out. So what I want from you now is put on your script writer hat and pretend you're a writer producer. Give me this character and what you would change to make that your single best diagnosis.
Like 2+ year history of persistence.
Right. When you say persistently,
Gaps are not longer.
good. Right. Ready? Got that? Right. So we need a prequel. That's what I'm hearing. Right. I really want you to get into this idea of being that producer. If you want to create this prequel, or at least flashbacks. Hollywood flashbacks, not PTSD flashbacks. Where we can actually see this persistent state defined by the American Psychiatric Association, the individual not without psychiatric model, right? And there's 2 years of pretty much the same criteria, right? There's significant overlap with regard to sticky gaps. Now, individuals, and I don't think this will come up on an exam. I think the board is much more likely to test you on your knowledge of that those parts of the definition, and not the actual quantifiable sticky gaps or the actual criteria themselves. But there are a couple of criteria that are different and unlikely to actually be tested on, but we may as well state them out loud. What are the 2 criteria of sticky gaps that are not reflected in the definition of dysthymic disorder or persisting depressive disorder?
SI.
Right. And the other one is several more aggregation. Those are the 2. Just trying Jeopardy. Right. All right. So another illness in this chapter.
What adjustment disorders fall in this chapter?
I'm gonna say yes, because I want to qualify it. But officially, that'll be in the anxiety disorder, right? More specifically, I think the trauma and stressor related disorder chapter in the DSM.
Okay.
But yes, because I'm hearing the words in your mouth, adjustment disorder and depression. That's a very clear differential. So let's talk about that. What is this? And then I want you to get put on your little producer hat and tell me how you would build this character, change the plot, whatever.
Less than 6 months of a reaction to an event. And the like reaction had to start within 3 months of it happening.
Right. So in this case, it would be depressed mood. That's the direct result, the temporal consequence of stress. And then the exact correct path, the board is going to really require you to know the operational definition of cause and effect in psychiatry, and you said it. That is the onset, in this case, depression, is within 3 months of an identified stressor and does not persist beyond 6 months once that acute stressor terminates. But the emphasis here on acute. The board is not likely to give you an enduring stressor. In real life, that's not the case. Most stressors are enduring. But when you're testing, when we're testing your knowledge of the definition, we're going to keep it to an acute stressor. And there you need to know the operational definition within 3 months of the stressor presenting, and then not beyond 6 months once the acute stressor terminates. That's adjustment. So that could be applied to disturbance of conduct, anxiety, and then combination.
Is there a diagnosis for when it's been over 6 months?
What if I think those habits are enduring?
Yeah. So in clinical practice, yes. So now if you have an enduring stressor, it gets complicated. And I don't know if the DSM, and it does simply capture what that means. So it's not going to appear on the board, right? However, of course, keeping the differential would be major depressive episode, right? Anything else published in this chapter on depressive disorders? And forget substance abuse, forget use of medical condition. We already discussed those.
Grief or bereavement?
So persisting complex bereavement disorder is in this chapter. Or might actually be one of them. Yeah. I think it might be in the chapter that's in the appendix to be. Nonetheless, it belongs in the chapter. Some of your visionary is going to be in this chapter at some point. So what is it? I think we've discussed this or touched on this just last week, but it's always good to review.
It's described as like a pathologic response to a death of a loved one.
Define operationalized pathologic predicament.
Causes distress, dysfunctional.
That's number one, because bereavement is actually defined sentimental disorder. And often interchange with the word grief. Grief is the actual feeling, and bereavement is but both are quote unquote emotional. That's not the case for persistent complex bereavement disorder. Because here you have it persisting that is beyond the duration of which you would expect from a quote unquote normal grief reaction. And it's complex, meaning that even qualitatively there's a difference, right? And it really does bridge the gap to a major depressive episode. So the individual does not rule in for depression, but then again, what they're experiencing is beyond what you would expect when it comes to grief. Right? It does cause clinically significant distress, or I think there's one other condition that this depressive disorder chapter. That's it. Wait a minute. Yeah, no, I'm not saying yes. I'm saying that it's there. Premenstrual dysphoric disorder, which is not a mental disorder. So at some point, hopefully soon, they're going to remove it from the DSM. Although there's a potential hardship in doing that, in that it provides the best example of behavioral change due to an underlying medical condition. Right? So in this case, we don't say medical illness, but the medical condition is due to what? Hormone. Just that comes up all the time, right? Symptom onset is when progesterone is at its highest, and symptom offset is when it's at its lowest. So it's clearly due to underlying quote unquote medical conditions, specifically progesterone, and that comes up when it advances over time, likely not to but it is the final one in our discussion in the depressive disorder chapter review. Any questions about depressive disorders? We'll give it a couple more minutes. I know we started at 12:30, but because of, I think, patient level, we're going to end soon. at around 1 o'clock, so we're right at the top of the hour. Any other characters you want to discuss with? I do focus on the daughter, and I know we just talked about this last week, but it's probably good to end today with another wrap up of the substances that can induce associative states. That is what would be escalated in our medicine cabinet and what might he be getting his hands on that might be manifesting in him as dysphoria. So what are those substances that can induce dissociative states? And the hint is that they're the same exact substances that we would understand to induce psychosis. Same exact. So that's more, I'm talking USA or ketamine. So hallucinogens.
Micah.
Yes.
Inhalants,
And him, yes.
amphetamines. Was that it?
Three,
Alcohol. benzos.
alcohol, benzos, one more.
What's the?
Oh, so.
Psilocybin, LSD, ketamine, hallucinogens.
Okay.
Yeah, how great would it be if in the last 5 minutes, just down to the all that said, I do want to briefly talk about hallucinogens because you gave me a ton of examples here. What are the 3 subclasses of hallucinogens? Again, I think this is fair game on that side shot.
You said classes of hallucinogens?
I heard LSD and heard psilocybin. What types of hallucinogens are they? No. And yes, there are tons of ways in which you can categorize these. But if it's an IEEE classifies as number 1 psychedelic or psychedelic. Right? LSD, psilocybin, psychedelics. I heard ketamine. I'd also include PCP as what subcategory? Yeah, associates, right? Which might be the case here. And then the final category is one that we ordinarily don't think of, but probably as physicians we see the most of. Delirium. So largely anticholinergic, antihistaminic. But that'd be the 3rd spot. All right. Final thoughts?
Sorry, can you just repeat the 3 classes?
Sure. Psychedelics, LSD, psilocybin are a common example. Dissociatives, PCP, ketamine, common examples. And then the final one are delirium.
So those are the anticholinergics.
And yeah, and sometimes they don't. Yeah, so briefly, I mean, this is homework for you guys. Not really, but it would help me out a ton. For the 3 subclasses, we got Austin's 5 flicks that are movies that depict, for instance, psychedelics. So that's LSD and that's The Matrix. The Terminator, which is PCP and therefore dissociatives. So if you could come up with another awesome sci-fi thriller that depicts delirium, that would be awesome for a trilogy. I just can't. Doesn't find it. And the other thing, the Terminator's the 80s. Matrix, of course, is the 90s. So if you're getting something in the next decade, or even the previous, the 60s, I'm not necessarily against. It's an awesome movie, it's an awesome movie. So if you could fit it, progress through the decades, that would be awesome too. I just started to look at that. Final thoughts, questions? All right, guys, I'll post on X what next week's film is going to be. Any quick ideas of what topic went over? Think about it. All right, guys. Well, I did here. Thank you. Thank you.